Dear attendees, senior colleagues, and panelists, it is with great pleasure and ultimate honor I welcome you to the 7th session in 2021 and the 63rd session of the MEGA Medical Association. On behalf of the Educational Board of the MEGA Medical Association and the Egyptian Society of Anesthesiology, I would like to thank each and every one of you for the efforts you are doing to keep the flow of learning and the curve of education rising. Thank you for your time every week, your patience during the mishaps, and the non-interrupted support all the time. Today, we are welcoming back Dr. Samir Al-Ansari to our speaker side, together with Professor Dr. Adel Abdel Fattah Saleh, Professor Dr. Khalid Yassin, and Dr. Eman Nada. On the moderator side, allow me to welcome Professor Dr. Muhammad Ibrahim, Professor of Anesthesia and Intensive Care, Alexandria University, Cairo, Egypt. Dr. Muhammad is also the reviewer of the Egyptian Journal of Anesthesia, and he was the president of Alexandria Society of Anesthesia and Intensive Care 2019.
Thank you very much for the this heavy heavy meal of anesthesia tonight, and we'll end with the our dear Dr. Eman Nada. Dr. Eman is one of our colleagues in Alexandria. She was graduated from Alexandria. She got her master's degree and doctorate degree from Alexandria, and then she now is associate professors or assistant professors in Massachusetts University. She will speak about a very important topic tonight about the anesthesia for the spine surgery. Please, Dr. Eman.
Hi, thank you, Dr. Ibrahim, for the introduction. And thank you, Saad, for Dr. Mahdi for the invitation among this group of esteemed high caliber academicians in anesthesiology. So I'm going to take the direction now in a different way. We're going to talk about the spine. Apparently tonight we're covering different topics and we're touching on different organs. So as a neuroanesthesiologist, you are going to come across of spine surgery, and spine surgeries can vary from very small surgeries to very large surgeries. So the surgical pathology, usually the majority of disc herniations happen at the lower lumbar spine, and the anesthesiologist usually sees these patients in the form of Coda Equina syndrome or significant, like the indications for emergency surgeries or elective surgeries, significant motor deficits, failure of conservative therapy, or large extruded discs. The anesthesiologist also will be involved in cases of spondylolisthesis because of degenerative disorders and spinal stenosis. The anesthesiologist also will come across the spinal tumors, and there are multiple. Generally, there are two types of spinal tumors, either the extradural or the intradural. And the extradural is mostly due to metastases, and the intradural are usually benign, and the most common are schwannomas and meningiomas. So before I start in the anesthetic management, I wanted to make this introduction about pathology, and I'm going to move on the more complex spine surgeries. So one of the important procedures the anesthesiologist gets involved in is the scoliosis correction. And that can be extensive, and that can be a big surgery and has multiple considerations. So the most common type of scoliosis is the idiopathic, and usually this happens in the adolescents, young adults, or later, older children. And you can see also correction of scoliosis or kyphosis or spine disorders in the elderly, and this happens due to degenerative diseases. It's very important that we have an idea about the Cobb's angle, because this angle makes many determinations for the anesthesiologist. So the Cobb's angle is where they measure the angle to decide the grade of scoliosis. So on an X-ray of a patient with scoliosis, you get two trajectories, two lines. One that takes the upper level of the upper border of the highest vertebra in the curvature, and the one on the lowest level of the lowest vertebra. And then you draw two lines, and then you drop two perpendiculars, and between these two perpendiculars, you find this angle. Angle is less than 10 is considered normal, and angle more than 25, there is some echo evidence of increased pulmonary artery pressure. Above 40, it means that a surgical intervention is indicated. More than that, 65 means like this is expanding more, so this is coming closer to each other. So the scoliosis is more severe, means that the patient will have restrictive lung disease. More than 100, dyspnea on exertion. More than 120 is alveolar hypoventilation. So spine surgery or scoliosis can be done through posterior approach or anterior approach or a combined approach. And all of this has a significance. The posterior approach is done with the patient prone. The anterior approach, maybe it's made through two phases. Sometimes you'll need one lung ventilation, and you need like two types of anesthetics and two surgeries. Generally, for the posterior approach, which is the most common, the surgeon opens the intraspinal ligament, retracts the erector spinae on each side, and remove the spinous processes and facet joints, and then does decortication of the vertebrae and put some bone graft and align them together and put these kinds of hardware to fuse the vertebrae. So the anesthetic considerations of this is important, as this surgery is characterized by big blood loss and long duration, and that would result in hypothermia. Patients are in the prone position, which has its own problems by itself, which gets exaggerated depending on the duration of the surgery. And also your anesthetic is affected by the spinal monitoring, and you have to do some modifications based on that. You might run into a problem of venous air embolism because of the big venous blood vessels in the epidural space. So to avoid blood transfusion, patient can donate their own blood preoperatively, or we can practice acute normovolemic hemodilution, or we can use the intraoperative blood salvage, or we can use the antifibrinolytic therapy, or the deliberate hypotension, which is now an obsolete term. It's not used anymore, and it's harmful even. So this is something we shouldn't be considering in our modern anesthetic practice. And at the same time, we need to avoid hypothermia, because we know hypothermia decreases the coagulability and increases the bleeding. And meanwhile, we have to make sure that the patient in the proper position, because of the increased intra-abdominal pressure, will increase the venous pressure and will increase the bleeding. So the prone position has its own problems itself, and we're gonna go over this really quickly. I want to point out this is the Wilson frame, so we're gonna mention this later on, so just wanted you to pay attention to this kind of table. So the risks of the prone position, it increases the intra-abdominal pressure, and it increases the incidence of positional injuries. So we have to be very careful about the pressure points, about the abdomen being free and the eyes being free, and checking on the eye every half an hour and the eyes every half an hour, and make sure that the airway is secure, because once the patient is prone, and if you lose the airway, it's a catastrophe. So as you all know, prone position, you have to avoid thoracic and abdominal compression, maintain the head in the neutral position, not an excessive flexion, not an excessive extension, because this puts a strain on the cervical spine. You have to make sure that genitalia and breasts are free of compression, and avoid extreme positioning the limbs. The arms should be less than 90 degrees, because more than that will result in strain on the brachial plexus. A stretcher should be immediately available outside the OR in case we need to turn the patient to the supine position. An important problem that can happen with spine surgery, especially with the extensive long spine surgeries, is the postoperative vision loss. It's rare, but it's important. If it happens, it's a really big problem. So to understand this problem, we have to understand some concepts like the ocular perfusion pressure, which is equivalent to the cerebral perfusion pressure, which means the MAP, which is the mean arterial blood pressure minus the intraocular pressure. And it usually increases in the prone position and increases more over time and increases more with the fluid transfusion. And it can reach up to 40 millimeter of mercury, which is normally 8 to 20 after 6 hours in the prone position. It's important also to have some idea about the anatomy of the blood supply of the eye. So here is the internal carotid artery, and this is the ophthalmic artery that comes from the internal carotid and gives some important blood vessels. Here we have the posterior ciliary arteries and the central retinal artery. So postoperative vision loss, it's not a major problem. It's not a big problem. I mean, it's not a frequent problem, but it's important. If it happens, it's a big problem. So the incidence overall of the spine surgery is somewhere between 0.1 to 0.01, 0.1 to 1%, sorry. A study looked into large US database into all the causes of postoperative vision loss. And actually the highest incidence is not the spine. The highest incidence happens in cardiac surgery. And the incidence is 8.6 per 10,000. Follow that is the spinal fusion, not any spinal surgery. The spinal fusion, 3.09 per 10,000 for all fusions, less for the anterior approach and more for the posterior approach. And it's extremely low, the laminectomy, and that's can be referred to the shorter duration of the procedure, less blood loss compared to the complex spine surgery and spinal fusion. So many studies has tried to come with what are the possible reasons. So they found some correlations, but they don't know exactly which patients are going to develop the postoperative vision loss. So it's generally in the long surgeries more than 6 hours. It's generally with more blood loss, more than 2 liters. And whenever you use vasopressors, especially hypovolemia, which is usually unavoidable in big spine surgeries. And it's more in the horse-shaped headrest and the Wilson frame we have shown earlier, and it's more in the male sex and obese patients and diabetic patients. You cannot pinpoint which patients is going to develop the postoperative vision loss. However, these are the correlations. Out of those, they found the most important is the anemia and the hemodilution. So this is the prone position. It's very important to check on the eyes. So this is the mirror where you can check on the eyes every 3 hours. And this is the other one, the horse show. Also have to check on the eyes. Make sure that the eyes are free. At least there is no mechanical compression of the eyes. The reason the postoperative vision loss happens is because the blood supply to the optic nerve is sectorial and shows marked inter-individual variations and even varies within an individual from eye to eye. Eye blood supply, as we have alluded earlier, posterior ciliary arteries are end arteries. This is one other reason there is no collaterals. So the posterior ciliary arteries are end arteries. And there is also a watershed zone means like there is no communication. There are areas that doesn't get that much of blood supply. And there are, so these areas are more vulnerable to ischemia. So if you can see here, this is a watershed area. And this is very similar to this. You have water here, but you have this area where there is no water. So it has the same concept. Yes, you have some blood supply here, you have blood supply here, but you can see hardly blood supply in this area. And the postoperative vision loss has been divided into several types. Posterior optic neuropathy, which happens with the optic nerve outside the eye in the globe. Anterior, which where the optic nerve is affected just as it enters the eye. And central retinal artery occlusion. So the anterior ischemic optic neuropathy, which happens very close to the entry of the optic nerve in the eye, it happens in the anterior part of the optic nerve where the nerve enters the globe, and usually results from low hematocrit because choroidal, which are these blood vessels, small blood vessels, blood flow decreases with hemodilution, whereas blood flow of the retina increases. The other one, the posterior ischemic optic neuropathy, happens in where the optic nerve traverses the optic canal in the globe. And it happens due to infarction of the intraorbital portion of the optic nerve, and usually the visual impairment is severe. The central retinal artery occlusion, it happens due to embolic or ulcerated plaques from the apsilateral carotid artery. And usually this is one-eyed only, while the others are usually bilateral. Then there's cortical blindness. It happens from the brain itself, and usually this doesn't happen in spine surgery. It happens more with brain surgeries and general hypoperfusion, and it happens also in conditions where there's severe hypoperfusion of the brain. Also, the affection of the eye can be in the form of facial and conjunctival edema, and this is actually not uncommon if the patient is on the prone position for 6 hours and they receive a lot of fluid. It's very important, like it's not uncommon to see this. And when you see conjunctival edema, the importance is that it tells us there can be some form of laryngeal edema. So it gives you an idea that you have to make sure that the patient, to do the leak test before you extubate the patient. Whenever you do like spine surgery, especially complex spine surgery, so you come across with the problem of the evoked potential monitoring. So I'm gonna touch a little bit on the monitoring. I'm happy that Dr. Yassin did this earlier. So this is another kind of monitoring, that's the spinal cord monitoring. So this monitoring puts some demands on anesthesia. Neurologic evoked monitoring. So what we do usually do sensory evoked monitoring or motor evoked monitoring, or we don't do auditory for the spine. I'm so sorry for that. And visual, that's not for the spine. We do also EMG. And usually this is in the big complex spine surgery, spinal fusion of the instrumentation or spinal resection, or in cases of thoracoabdominal aortic aneurysm repair. Essentially, the monitoring is we receive a signal. I'm gonna go over this in a little bit. So you want to look for the onset of the response, the peak of the signal, and the duration of the signal. So latency is the time period from the stimulus to the measured response, and the amplitude is the measurement of the voltage of the response. Somatosensory evoked potential, it's also, it's a summation of several sensations. So the somato is the opposite to the motor. The somatosensory is you stimulate and you perceive the stimulus, you stimulate the patient peripherally, and you perceive the stimulus at the brain. And if you perceive the stimulus intact, this means the pathways are intact. The motor is you stimulate the brain or the spinal cord and you perceive the response at the hands and legs. And this tells you that the motor pathway is intact. Any change of these, or especially of the motor response, it makes us to look, makes us want to look and try to find what is the reason, because the worst reason would be a surgical injury of the spinal cord. The last thing, if you don't, like, this is very rare nowadays, I've never seen it done for so many years. If your patient doesn't respond, you don't get any response from the sensory or motor, so you have to do the wake-up test. The wake-up test was popular before we started to do neuromonitoring in the OR. So that's when you wake up the patient and lighten the anesthesia. So you see the patient move their legs or their arms, but you run the risk of dislodging of the central lines or hardware disruption from the surgery. So it's a very risky test to do. So the motor evoked potentials can be of two origins, from the nerve itself or from the muscle itself. And this monitors the anterior pathway of the spinal cord. There are many factors. The motor response is very sensitive to anesthesia, much more than sensory. So it can be affected by anesthesia itself. It can be affected by hypothermia, the temperature, hypotension, or technical factors due to surgical positioning. So before we can say that the motor is affected, we have to make sure that patient temperature is above 35, hypotension is corrected, and make sure that there is no disconnection somewhere, and you can switch to complete TIVA and make sure that it's not there. Then you can say there's some surgical reason. Important to say also, whenever you monitor the motor evoked potential, you get those responses in the form of the patient is clenching on in their jaw, and that can result in tongue or teeth trauma. So it's very important to have the bite blocks put bilaterally at the beginning of the procedure. Make sure that the tongue is free, because there are some case reports where the tongue was severely injured and resulted in postoperative mechanical ventilation because of the simple reason. So generally, like after we start induced anesthesia and like the neurophysiologist starts to put the wires in, and then we start our work, they start to monitor, and we start to adjust our anesthesia. Usually we use TIVA with a little bit of halogenated anesthetics. TIVA by itself has proven to not prevent recall, so it's preferable to use halogenated anesthetics with it. Something like half a MAC would be good for the recall, and at the same time wouldn't affect your neuromonitoring. However, if the patient's having baseline deficits and having neurological issues from the start, like this small amount of the halogenated anesthetics might affect it. So these are the things that can affect the signal: the halogenated anesthetics, nitrous oxide, hypothermia, hypotension, hypoxia, or electrical interference. The other kind of monitoring is called EMG, is where you stimulate the hardware and you see the response in the muscle to determine whether the screws have breached the pedicle or not. Supposedly, if you're putting a screw like this, it should go into the pedicle inside the bone, and the bone is a good insulator. If you get a response in the muscle, this means the screw is not in the right place, or maybe even violating the nerve itself. So as we mentioned earlier, you can use a small amount of halogenated anesthetic. 0.5 or 0.75 of halogenated anesthetic can help you decrease the amount of TIVA, and at the same time improve the recovery time, and at the same time improve the recall. So this is an algorithm. What would you do? What would you do if you lose the signal? Or the neurophysiologist tells you that I can't get the signal. So first, optimize physiological parameters. The blood pressure, oxygen, hemoglobin is very important, temperature, glycemic control, and electrolytes. If you adjust it and still there's no signal, stop inhalational agents, go completely TIVA. You may use ketamine to augment, ketamine and etomidate actually augment the signal. We can't use etomidate as infusion, so ketamine can help augment the signal. Still, you don't get that. Reassess signal at steady state. Here, like if you lose the SSEP, so you have potential spine injury, consider reversing spine correction. So the reason might be surgical, the correction may be, the spine may have an overcorrected and the spinal cord is stretched or the nerves are stretched. So here you tell the surgeon, consider reversing spine correction if possible, confirm with neurological exam immediately after the patient wakes up. If the problem is in the MAP or the EMG, verify train of 4 response, reverse. And if there is no train of 4, actually the neurophysiologist can do the train for few in the 4 limbs at the same time. So there is a potential of nerve injury, and you have to tell the surgeon that there is a problem. So the surgeon, or you still didn't get anything and the surgeon doesn't feel there is a surgical problem, you might go and do the wake-up test. I'm done with the scientific part of the presentation now. I just wanted to inform my colleagues in Egypt that we have great universities in Egypt. I'm part of this International Council on Perioperative Neuroscience Training. So this is an international council that accredit neuroanesthesia programs all over the world. I'm sure that we have all the capacity in Egypt to do it, but we need the structure. So you might need to go to this address and see for, look for the guidelines and what's required. So you can have internationally recognized fellows from our universities. It generally needs the fellow to go through a year and to have a certain number of craniotomy cases, certain number of spine cases, certain number of neurointerventional cases, certain number of neuromonitoring cases, and there should be a program director. And actually, this is for anywhere in the world. We do accredit programs from Europe, from Asia, from everywhere. So this is something I think we should consider in Egypt. It will need certain criteria. It will need a program director, which can be a lecturer, assistant professor, or professor who is experienced in neuroanesthesia and have publications, and it will result in greater quality of trainees in this subspecialty. Thank you so much. I'll be happy to answer any questions.
Thank you very much, Dr. Eman. Very, as usual, very illustrative, informative lecture. I have two questions, maybe two questions.
Yes.
The first, the postoperative vision loss, is it a self-resolving alone? In some cases, they say that it will resolve by itself, maybe 3 months, something like that. And what is the medical legal aspect of this?
Medical legal? Yeah. So it depends. Sometimes it doesn't resolve. And actually, there is a study that says it cannot be an explicit vision loss. It can be just, as you've seen in the lecture, there's watershed areas. It can be in the loss of certain areas of the field. And patient may not recognize it except by formal ophthalmologic exam. It improves over time. Usually any neurological issues improves over time. Over how long, I don't know, but going to baseline, I'm not sure of that also.
Okay, any medical legal insight about this issue?
Yes, yes, it's a major problem. Like patient can have their spine fixed, then they can walk, but they cannot see. It's a major problem.
Major problem.
But
okay.
Like, how do you defend yourself is just to do everything right. You're not required to prevent the complication, but you have to prove that you avoided the hypotension, you avoided the anemia, you check the eye every half an hour or hour and documented this in the chart. We just have to follow the guidelines. Okay,
another question. The spine surgery is a lot of blood loss. You mentioned to conserve the blood loss by auto transfusion or acute normoglemic dilution or salvage technique. Most of the surgeons here in Egypt, they ask for hypotension or hypotensive anesthesia to reduce the blood loss. And this hypotensive anesthesia is very critical in such patient, very, very critical in such patient.
Yes.
What is the effect of the evoked potentials, or effect of hypotension on the evoked potentials? Suppose that my patient is hypotensive. What is the limit of the mean of my MAP? What's my limit to avoid from the anesthesia, from hypotension, the injury or ischemia of the anterior spinal cord or something like that? That's spinal artery, Adam's artery.
That's a very good question, Dr. Ibrahim. So when we started our training, like the hypotensive anesthesia was very popular concept everywhere. When I started in the 90s. However, over the years now, it's no longer accepted. Now it's wrong. And
Yes.
it's our job as anesthesiologists to work with the surgeons around us. So the effect on the evoked potentials, it suppresses the evoked potentials, because if you have the evoked potential, you're not getting the signal. The first thing is to improve the hemodynamics. And your limits are 20% of the baseline. Like if the patient lives on 140/80, 20% of the systolic, diastolic, or the MAP is still acceptable. And it doesn't affect only the spinal evoked potential, it affects everything, the eye, it affects the heart, it affects the coronaries, everything. So it's not accepted now. And like if the patient develops blindness, and in the chart it shows that the patient was hypotensive intraoperatively, the anesthesiologist is in trouble. So the use of vasopressors and these, like we use a lot of vasopressors, almost everybody. As you know, our anesthesia, anesthetics is always vasodilators and negative inotropes. So always also the surgeons will ask you, tell you like, I have a lot of bleeding, you have to go hypotensive. Actually, most of the bleeding in the spinal surgery is from the epidural veins. And it is not affected by the it's not affected by the hypotension.
Yes, I think this is very, very important message to convey to our staff or our colleagues everywhere. Take care, the hypotension or hypertensive anesthesia is condemned, or it is contraindicated nowadays in the spine surgery, especially in the spine surgery, which is very, very important. As I said, it is not related only to the Adam's artery or the spinal cord injury, but as you said, the vision loss, the mean minus the intraocular pressure, and this is a lot of things. Thank you. What the usual technique you are doing to conserve the blood loss? Because otherwise you will transfuse a lot of blood for such patients. Sometimes you need.
We use the cell saver a lot.
Cell saver.
Contraindications of the cell saver is the cancer, if the patient has cancer, so we can't retransfuse it, or the infection, sepsis. The other thing, we use the antifibrinolytics, tranexamic acid. It helps to conserve the blood loss also to some degree, but it's contraindicated in patients with previous thromboembolic disease or stroke or MI or DVT.
Yeah, the same dose you are mentioned, 10 milligrams, something where we are giving repeated or infusion or what?
Yes.
And especially are doing give it intraoperative before surgery or preoperative. Intraoperative, you repeat it or once.
You run the infusion. You start
the infusion. In 1 milligram, right?
Yeah.
Okay. Any question from the dear panelist?
Dr. Ibrahim, please.
Professor Eman.
Yes. Dr. Adil, Professor Adil.
I am happy to hear this fantastic presentation. What about the use of halogenated anesthetics in small concentrations and muscle relaxants, and then the use of evoked potentials? There is confusion about that. How can you diminish the level of the concentration or the concentration of the anesthetics, and what you can reverse the muscle relaxant? Or how can you do that?
Yeah, thank you, Dr. Adil. This is a very good question. So the inhalation anesthetics, I usually use the half a MAC and with the TIVA. So that can make me use less TIVA, and at the same time, less awareness. And TIVA is cumulative over time. Many hours use the TIVA.
But this concentration cannot affect the the evoked potential?
Yeah, so I always communicate with the neurophysiologist. I ask them, how's that signal? If the signal is okay, it's fine.
So the neurophysiologist is attending all the time?
Yeah, he's
Yeah,
all the time
Yes.
there.
Yes.
The other thing for the muscle relaxant, there are two ways. Sometimes some surgeons want a baseline neuromonitoring. So we start with succinylcholine, and then we start the TIVA. And
For how long does succinylcholine?
For intubation only.
For
And then
intubation?
will depend
then
on
you-
the remifentanil will work like make the patient more like work in the place of the muscle relaxant, the remifentanil.
How?
Yeah.
How remifentanil is an hypnotic or
It's not muscle relaxation, but it decreases the mobility because the spinal cord is full of mu receptors, and the remifentanil or any opioid in general. But the good thing about the remifentanil that you can.
But about the remifentanil, you use the same concentration, the clinical dose, or you give more doses?
I use remifentanil infusion 0.1. But before
0.1.
we had the remifentanil, we used to use the sofentanil or fentanyl. But the good thing about the remifentanil, it doesn't stay in the system that long, so we can.
Short acting.
Yeah.
Okay.
For the muscle relaxant also, it's not contraindicated, but it depends on like the team. There are some neurophysiologists don't like muscle relaxant.
So
You can use a small amount.
I mean, you can reverse it inside the operation, during the operation?
You can, yes.
You can give
Yeah.
prostigmate, for example.
You can, yes.
You can.
Or you can use small amount that allows you to have a signal, but you compare to the baseline one. Yeah, if you have like, if you use 20% muscle relaxation, you will have some response. So the change from that baseline response is your is your change. The neuro monitoring is about the change.
Yes.
Trend. It is a trend.
Yeah, usually there's complete disappearance is not common. So there is decrease of the signal.
I have another question about the blindness.
Yes,
do you know the most common cause of blindness is thrombosis of the central artery? That's right?
No.
Or not?
I think it's more in cardiac surgery because of the period of the anemia.
This will lead me to the second question.
Yes.
Second question is you use the antifibrinolytics.
Yes.
And the traziololio are known to produce some sort of thrombosis during the operation. In cardiac surgery, the use of the antifibrinolytics have been stopped now because of the coronary thrombosis, may lead to coronary thrombosis.
Yes.
I mean, exactly the proper, one of the
It's prothrombogenic.
Prothrombogenic.
Can I add a little bit? Yes, I think in the CRASH 2 and the CRASH 3 studies, which is very, very huge studies published, the CRASH 3 just 1 year ago, it is used now. It is used. It is not thrombogenic, provided that the patient is not, as you said before, as you mentioned, Dr. Eman, not we have MI or something like that, or have thrombotic or DVT or something like that. It is very important.
But many of the cases have been reported as thrombosis.
Maybe with the old one, the aminocaproic acid, maybe, sir, you mean that?
Proteinin.
Proteinin have
been forbidden.
Yeah, that's forbidden, right? I agree with you.
Aproteinin.
But the tranexamic acid
long time ago, I used aproteinin.
Yeah,
I used aproteinin. It was very successful in controlling the field from blood loss. But the incidence of thrombosis have been shown in the literature that it's leads to contraindicator.
But as I know, Dr. Eman, you may be, correct me if I'm wrong, the main cause was not thrombosis of retinal artery thrombosis. It is not like that.
The main cause is anemia. That's the main
anemia.
More than even hypotension.
After spine surgery, the main cause is not thrombosis. It's not
thrombosis.
After
spine surgery, that's why we have to be low threshold for transfusion and spine surgery. What we allow in other surgeries, we don't allow in spine and prone position for long procedure.
Professor Assam, you have a question, please?
May I ask some questions for Dr. Eman, because I am working in the field of neuroanesthesia since 25 years, and I am interested in the neuroanesthesia either craniotomy or in spine surgery. Regarding to some of the comments regarding to the tranexamic acid, we are using here as a protocol in King Khalid University Hospital, tranexamic acid as bolus dose 2 grams, 1 dose for the adults, and 10 milligrams per kg per hour as an infusion for the spine surgery. And it helps a lot for preventing and for controlling of the blood. Regarding to the permissive hypotension, as you said exactly, this is now, it is an old fashion. It is obsolete now. Nobody is using this technique, even in the ENT surgery. Even in the ENT surgery. The trick here for controlling of the blood pressure and controlling of the bleeding is not the blood pressure. It is the heart rate. So if you maintain the blood pressure with normal or even above normal, and you are controlling the pulse or the heart rate for the lower limit, I mean for the level of the 50 or less than 60, the surgeon will not ever complain of bleeding. This is the trick. And how we are using this, as you said, by Zytiva, by using propofol and remifentanil. Regarding to the helping for the propofol and remifentanil, there is a very fantastic drug we are using as muscle relaxant, but it doesn't give muscle relaxation, and it helps in sedation and analgesia, magnesium sulfate. Magnesium sulfate is a very interesting and very nice drug for every surgery, and specifically for using the TIVA. When you are using TIVA, it doesn't affect on the monitoring evoked potential at all, even sensory or motor evoked potential. When you are using magnesium sulfate, it helps in reducing the total analgesic effect of the propofol and the remifentanil, and even it helps post-operative in reducing the PCA for the patient, because the patients who are doing scoliosis, they need very potent analgesia post-operative, and as you know, the PCA it has a lot of disadvantage regarding post-operative nausea and vomiting and drowsing. So the use of magnesium sulfate is fantastic drug when you are using this magnesium sulfate. Regarding to the visual loss, I agree with you totally that it is related to even ischemia or to the anemia, and it is observed most probably not in the spine surgery, because the spine surgery most of the time the position is zero position, prone position, but zero position. It is observed most commonly in robotic prostatectomy. In cases of robotic prostatectomy, it takes long time, and the patient himself is 70 or 80 plus, and it has a lot of complications, ischemic heart disease, uncontrolled diabetes, and the head, it becomes steep down up to the ground for a long time, more than 6 hours or 8 hours. That's why most of the paper, it speaks about the visual loss in cases of robotic prostatectomy. Last thing, I want to just to comment on something which is not common. Not please for our anesthesiologists who are not doing prone position, the use the regular tube. Don't you, because the regular tube is the reinforced tube is not an indication in the prone position. So we are using the regular tube size type, the regular tube size, not the reinforced or the armored tube. And as you said, it is mandatory to put bite block because using evoked potential, motor evoked potential, the patient is biting like he tetanus. He may break his teeth. So it is very important to use the bite block. Last thing is the visual evoked potential. Is it applicable during anesthesia? I think it is applicable in the clinic. Visual evoked potential. We cannot use visual evoked potential during anesthetizing the patient. All the evoked potential can be used except the visual evoked potential.
Okay, I will.
Thank you so much.
Dr. Assam, there is one question,
Yes.
it's for you.
Yes.
What?
Yes, sir.
Not using reinforced tube?
Yes,
For
it is not indicated. It is not indicated, sir. The only indication, the only absolute indication for reinforced tube is the sharing airway.
Okay.
Sharing airway, not the prone position. If you fix the regular tube in the prone position, no need for using the armored tube. And another thing, if you send the patient, for example, after long procedure or any event for the ICU to Prof. Samir Ansari, he will complain of the reinforced tube.
Right.
For suction. As you know, this is a suction and the biting on the reinforced tube is very bad.
Okay. Back to Dr. Eman, we have some questions.
Yes.
Do you prefer muscle relaxant infusion or boluses?
When we do monitoring, we don't do muscle relaxant except at induction. We do either succinylcholine, which wears off after 10 minutes, or we do non-depolarizer, which wears off after 20 minutes. During this time, the neuro physiologist is placing their wires. So by that time, the muscle relaxant worn off. Or if we need to reverse it, we reverse it with neostigmine. But we use it once at the beginning, and that's it.
Okay.
Regarding muscle relaxant, Prof.
Yes,
Brahim,
sir. Yes, sir.
If you please, Dr. Iman, we are using regularly rocronium.
Yes.
Right.
In the
this is
induction,
what yes,
are using
I think
rocronium, and it fades with 30 minutes maximum until the neurophysiologist is doing his monitoring and fixing his monitoring. So when returning back to the train of 4, it will return. For the train of 4, most probably 70% or 60%. If the residual of rocronium, you can give.
I agree with you, sir. Some other questions, Dr. Eman, also.
Yes.
What vasoconstrictors do you prefer, and what about the dexmedetomidine?
We use always phenylephrine infusion, almost in every case. And phenylephrine infusion with remifentanil gives you very bad bradycardia, but it's easily reversed with some glycopyrrolate. And usually infusion, because these are long surgeries. Ephedrine, we can use it in the middle for boluses, but you know, ephedrine has the property of tachyphylaxis. After you use it a little bit, you can't use it. The other part of the question was what? What
is about dexmedetomidine use?
Dexmedetomidine is a very good drug for analgesia.
Yes.
It gives you opioid sparing, but it has 2 problems. It will give you bradycardia, it will give you hypotension, and it will delay the recovery if you don't shut it off early on. So you can use it in small doses and you can turn it off at least an hour or something before you wake up the patient.
If extubation happened intraoperative, accidental extubation, what?
That's a very good question.
Yeah.
That's a catastrophe.
It happened. Yeah, it happened. I think with all of us, it happened once at least.
You will make like this, bro.
Yeah. So of course you have, if you have to move the patient on the stretcher and intubate them, you have to do it. This is life, like life or death.
Yes.
But the most important thing is when you intubate the patient, you pay close attention to fixing the tube. Make sure there is no saliva. If you have to give glycopyrrolate, you give glycopyrrolate. If you have to use the glue to glue the tube, you glue the tube. So prophylaxis here is the most important thing. I overdo it and people think I'm crazy overdoing it, but
Yes, better.
I
Yes.
try to avoid.
Okay.
Prof.
Still
Ibrahim,
some.
regarding your question, regarding
Yes,
to the accidental extubation,
Ah,
this is very important question, and it is
yeah.
not funny. It
No,
happened
no.
already. But
It's disastrous.
the importance while transferring the patient in the prone position, you should transfer the patient while you
Yeah, sure.
disconnect everything. I am always saying for my junior, the last thing to be disconnected is pulse oximeter. The first things to be disconnected is the tube and the pulse oximeter.
Right.
So it is very important for transferring of the patient. This is number one. Number two,
Yes.
we have now, because we have facilities in Saudi Arabia, what is called Jackson table. Do you have Dr. Eman in America?
Yes.
Yes, Jackson table, you can anesthetize the patient on the supine position. And the table is rotated.
Yes.
180 degree. So there is no chance for disconnection.
Okay. I think now we reach to the maybe some questions. Also, Dr. Muhammad Sulaiman is, I suggested laryngeal mask airway until intubation. Anyhow, no, you cannot, something like that. Anyhow, yeah, sure. Anyhow, I think we reach to the end of this mega line course, which is very, very valuable, very informative. I'm very happy on the personal level. I'm very happy to share this event with this figure eminent in the field of different fields of anesthesia and intensive care.
Very grateful for this opportunity.
Yeah, thank you very much, Dr. Eman, my dear fellow, and
I am very honored.
Yeah, all of us very honored to be to share this event. Thank you, Professor Assam, my friend, my colleague as a moderator, and the all guest speakers. Thank you, Professor Ansari. Thank you, very Professor Adil, and my dear friend, Professor Khalid, and Professor Eman. Thank you very, very much.